Hi, I'm Dr. HANS. In 2000, I received my MD, started on a path of infectious diseases and internal medicine. In 2017, I became a rare disease advocate because my son was diagnosed with SYNGAP1 syndrome. In 2021, I joined industry to work on rare diseases as much as possible. And I enjoy talking about rare diseases. The topic is supposed to be, I think, a little bit more enjoyable in the sense of a month ago when I was trying to get to the mic, I could have talked about how the Angelins community should be celebrating, that Ultragenyx and Ionis had dosed their first subjects a part of ASO trials, that Roche had published their ASO experience in Nature Medicine, fantastic. And then I would segue into ex vivo lentiviral correction therapy, which is something the Angelman's community and the SYNGAP community have in common. But the past 2 weeks have been absolutely dominated by Sarepta and Elevidys. And, I had spoken about this earlier because in March, they reported the death of a teenager and there was sort of a concomitant CMV infection. And as an infectious disease doctor, CMV is an infection I'm very familiar with, a lot of experience over the years, a healthy respect for. And from my standpoint, I wanted the case described. I want it published, review the data, and hopefully we see, that the CMV was a significant contributor and nobody gets scared of, Elevidys AAV gene therapy because it holds such promise for the rare disease community. And then in June, a second death was reported following Elevidys. And minimal detail, I didn't really find anything beyond the acute liver failure. We know this is a risk, right? So we say, oh boy, the timing. And then there's an investor call and then a sidebar comment to a biotech reporter that they had a death within their limb-girdle muscular dystrophy program. Many people are like, why didn't you tell us in the investigator? It was immaterial. It's like, it's absolutely material and is in the same vector. You need to disclose this. And this is when, the FDA is starting to say, hey, you need to back off on your, shipping to non-ambulatory kids and so forth. And you can follow the progression in the announcements from Sarepta, right? So there's the initial one in March. There's the June one saying, all right, we're going to up the safety monitoring, and we're going to mitigate against immune response with additional immunosuppressants. And then there's the third one, barely a week ago, on an 8-year-old down in Brazil, right, where they're having their sort of flu season while we get the summer off. And they do report that it's unrelated to Elevidys, that the flu was involved. Okay, but wow, the timing is just Murphy's Law, right? And the FDA says, pause. Fine, that makes sense. Though it seemed like originally Sarepta was like, no, we're not going to do that. That's going too far. Listen, but there's your spouse, then there's the Almighty, then there's the FDA, so the IRB. So in the hierarchy of who you listen to the FDA. And they did pause. Then to top it off, the EMA comes through and says, we just can't approve this. It just doesn't work for us. That's unfortunate. It shows you how controversial this was and getting into the nitty-gritty details of benefit to the kids and adults, and videos of treated individuals bounding upstairs compared to what they would struggle with, before their treatment. Now, at least and my big concern was for the patient community, right? You can say I'm a pharma shill, you can say I'm a doctor is protecting them or whatever, but the patients are at the heart of it, and they've got to go through this roller coaster and shake their heads and wonder, what is going on, and what is what are we going to do, right? For ourselves, for our loved one, etc. Thankfully, I think it was yesterday, the FDA pretty much said we are, not going to continue holding Elevidys for the ambulatory population, which makes a lot of sense. And what it comes down to is this risk-benefit analysis that goes on and on. It applies itself to every circumstance, every type of patient. Look at the time of year now, right? I mean, when you've got the flu in Brazil and so forth. So, some of these risks are known. We know that liver reactions are a part of AAV gene therapy. Going back to the hemophilia data, the poor kids with the Astellas experience for X-linked myotubular myopathy, you name it, Zolgensma and a couple of deaths in Central Asia because maybe the steroids weren't tapered slow enough, what have you. It's part of the consent to receive an AAV gene therapy. But there still needs to be a strenuous effort at transparency and reporting these cases. And that was the point I tried to make earlier with the first death in CMV. Is it a primary infection the first time? What an unlucky kid that would be. Or is it a reactivation? And could it have been managed differently? Where are the lessons, right? With the second one, there's very little to say. Nothing's been really disclosed. And at that point, a pause was completely reasonable. You also say to yourself that with two non-ambulatory, you look at the package insert, you say, is the dosing appropriate when the body is unable to walk and the muscles atrophy and the change in the proportion of your body weight that is made up by muscle, which Elevidys is targeting, right? So the muscle bulk goes down. The dose doesn't change necessarily. Are they seeing too much in terms of their dose? And with the third one and the flu, it's early, and of course, they deserve a chance to write it up and talk about it. With the flu, an immune compromised kiddo hopefully got the vaccine. Did it work? And then, one of the pearls I picked up in management was if, I've got some 80-year-old former smoker, frail pulmonary status, maybe they're on oxygen, and they say, Doc, you got to get me through this flu season because in the spring, my grandchild is marrying and I've got to be there. At that point, it's like, okay, buckle up because you're going on Tamiflu. 25 milligrams, whatever it might be, every day we're going to prophylax you from October through the wedding. And if you want to celebrate the next day by stopping your Tamiflu, so be it. And that's what you do when you know you've got a frail individual in an exposure of risk, in an ecosystem that is unfavorable for the time being, hopefully. Right? So these cases need to be published. They need to be talked about. The other thing that strikes me is that, with the first death that was reported, Sarepta made the point of saying there have been 800 doses given out. So this is our first one resulting in a mortality. That means, and if you look at the package insert, and I'll flip to it because I think it is, worth illustrating that the FDA Sarepta describes in their package insert 214 patients being dosed as a part of the clinical studies. So that means there's over 500 outside of that. Where is the real world evidence team who is just salivating to get their hands on the real world data of those 500 patients. It's going to be messy. You've got to clean up the electronic medical record that you receive. Who knows? You've got to get your hands on that. You've got to talk to the docs and say, what's your opinion? Use it almost like a clinical global impression, right? Or a investigator global assessment. These are outcome measures. So psoriasis uses an IGA, an investigator global assessment. It hasn't been validated maybe in Duchenne, but you've got to use the data. There are over 500 others who have been treated, and figure it out, model it, AI it, do something, digital twin. I don't care. These are huge decisions. The EMA says, no, thank you. Parents don't know which way to go. And the docs are like, holy cow, the first rule is do no harm. So is this worth the effort? So, what comes to mind, there's a few things, right? I mean, I thought to myself about a REMS program. This is where a risk evaluation and mitigation system is put in place for medication. Tysabri was one for multiple sclerosis where the signal was PML, progressive multifocal leukoencephalopathy. And this is a JC virus waking up from its slumber. And, it's a form of educating everybody intensely. This is what you need to watch for. This is what you need to worry about. There was an antibiotic going way back called trovafloxacin. And there it was a great antibiotic, it seemed, right? Active against gram-positives, negatives, anaerobes. It was approved and everybody started using it. And the signal came through that it was associated with liver failure. And then they pulled the plug on it. And we probably lost a good antibiotic. We always used to talk about it in the clinical investigator training program. And Bob Rubin was a co-director there. And he thought that its liver failure rate was probably less than Augmentin. And I reach for Augmentin twice a year probably with sinusitis. So you can't overreact. You also can't drag your feet. There's the story for me, at least, of Stavridine in HIV care. And we needed it at the start. The HIV-infected population was desperate. But as time went on and NRTIs got better and better, and we had additional classes being added on, and this was a poisonous medication. And I've seen it, when providers were unfamiliar with it and kept it going because the patient was on it. It made your skin crawl when you came on board and said, we got to stop this. I'll talk to the provider, but we can't continue this in good measure. And eventually states started pulling it from their approved medication for, Medicare, Medicaid, and the FDA eventually pulled it, and it was clear it needed to go. I hope that does not happen until we are fully informed on Elevidys. It's too significant to a rare disease population to not really do a deep dive on this. So I hope that happens. I hope the Duchenne's community has the strength to go through it. I really hope those brilliant quantitative pharmacologists, DMPK, translational disease modeling, QSP folks just get their hands on this and figure it out. And the real world evidence folks, because that is a very worthwhile mission to figure out how to use this medication safely and effectively. So I'm going to wrap it up, and thanks for listening.